couple more people trickling in.
Go ahead.
All right. Hi, welcome to Project Echo Geriatrics. I'm Kate Bennett. I am the medical director for our Project Echo Geriatrics here, and a geriatrician here at Harborview at the UW system. We're going to start off, as we usually do, with our mini didactic, and then we'll go on to cases. And after the didactic, I'll introduce all of our panelists, some of whom are trickling in because they're finishing up clinical responsibilities. But thanks to all of you for joining us. We'll have a few other groups joining in as well. But our speaker today is Zach Marcum, who is also one of our panelists, and he is a pharmacist who's expert in geriatric pharmacology and does a lot of research in that area. And one of his realms of research that he's done is on medications that increase your risk of falls. So he's going to talk to us specifically about that. Thanks,
Right.
Zach.
Thanks, Kate. So as she said, we're going to be talking about medications and falls today. I'm going to move pretty quickly through the slides. We're going to cover quite a bit, but pretty much from a high level. So we'll talk about the factors that increase the risk of bed-related falls, some of the most common culprits. We'll talk about some possible solutions for how you can implement med-related fall prevention in clinical practice. And then I just wanted to point out a couple resources as well. So what are the risk factors for medication-related falls? We know that falls can be caused by dozens of different risk factors. Meds are just one of them, so keep that in mind. One of the biggest risk factors is polypharmacy, and we use that word quite often, and it means a lot of different things to a lot of different people. Some people use a term, polypharmacy, to mean more than 5 medications. In the long-term care setting, it's usually more than 9. But really, you know it when you see it, and I think in today's case, that might be the situation. It's really more medications than are needed for that individual patient. In particular, the more medication somebody's on, the higher their risk is for having an adverse event. And in particular, you run into some problems with risky medication combinations like benzodiazepines and opioids, for example. That's really a recipe for disaster in terms of fall risk. Other risk factors include having a history of falling. That's probably your strongest risk factor moving forward. A recent start of a medication. So for example, an antihypertensive that maybe was started, lisinopril 20 or 30 milligrams, too high for that patient. And then on the other side, an inappropriate withdrawal of a medication, whether it's clinician instructed or patient initiated. You can have exacerbation of the underlying condition or actually physiologic withdrawal where the symptoms could lead to falls. So this is just kind of a word of wisdom when you're reading the literature on meds and falls. We know that falling is commonly studied in geriatric research, and medications are usually addressed, oftentimes just as a covariate. But when you're reading studies, these are just a couple points I'd like you to remember. So a lot of studies have a limited ability to measure dose response and duration response. And so those are really, really important things we look for when we're trying to figure out if this is causally related. Another issue is confounding by indication. So for example, an individual receiving an antidepressant is very different than someone not receiving an antidepressant by nature of receiving that prescription. And so that's a bias that really needs to be paid attention to. So when you're reading studies on meds and falls, really pay attention to that. A lot of people don't really have the luxury of looking over years, periods of time for medication exposure. And then when older adults buy over-the-counter meds, that usually does not issue a pharmaceutical claim. And so that data does not end up in the studies. And things like Benadryl, for example, that we know increase the risk of falls are commonly not included. So just keep those things in mind as you're reviewing literature moving forward. Anytime we talk about drugs in older adults, of course, we talk about the Beers criteria. And I talked about this a few months ago now, but really when it comes to falls, they have a drug-disease interaction criteria that I'd like to address. These are the med classes that are included. When you look at this, the main message here is CNS medications. So anything that really is having an impact on the brain could and can increase the risk of falling. And I just wanted to point out that the opioids, as a reminder, were added in the most recent version of the criteria. So the rationale for this criteria is pretty self-evident. It can impair psychomotor function, One important point is within the benzodiazepines, in years past, it was thought that the short-acting ones were safer relative to the long-acting ones in terms of fall risk, and that simply has not been shown to be the case. And so benzos in general should be viewed as high risk, class-wide effect. Clinically, the way you should think about this is that if you have to use one of these drugs, really look at all the other medications that the individual is on, see if there is the potential to decrease the dose of one or two of those drugs, or maybe even discontinue. And so the goal here is to really reduce CNS burden. It's easier said than done, of course. So the AGS recommends to avoid these unless safer alternatives are available, and they do provide some caveats. Of course, anticonvulsants have appropriate uses, and opioids have a couple clinical scenarios that are really appropriate. This is just an example of a study that was used to justify the Beers criteria. So you can see here on the x-axis the increasing dose of CNS medications, and this is kind of a cumulative standardized dose across all antidepressants, anxiolytics, antipsychotics, etc. And you see this nice dose-response relationship. So the higher the dose, the higher the risk of recurrent falls. You're probably all familiar with the STEADY toolkit, which is from the CDC. Dr. Phelan, I believe, has spoken about this before. It stands for Stopping Elderly Accidents, Deaths, and Injuries. And this is just one of their materials that they put out, a fall risk checklist. And I've highlighted the medication component. Again, meds are just one part of fall risk assessment. But here you can see, the things we just talked about, CNS or psychoactive meds, meds that can cause sedation or confusion, and meds that can cause hypotension. So these could kind of be red flags when you need to do a quick review of a med list to kind of raise awareness. This day and age, everything is really focused on IT interventions, and this is an example of a project that I've been working on along with Dr. Phelan and the CDC to develop the STEADY toolkit as an embedded instrument in an EHR. And so you might see things like this. You might already have toolkits like this in your practice. If not, these might be rolling out in the future. And so again, the STEADY toolkit is a comprehensive fall risk assessment, but for this project in particular, we have a specific tab on medication review. And these drugs were those drugs listed on the Beers criteria. And so, for example, this patient is on a medication that increases the risk of falling, and the practitioner can make no changes if they think no changes are needed. They can make changes, or they can look for more information at the resources at the bottom. They can add vitamin D to the med list, and so on. So it's meant to be seamless and streamlined. Of course, there are always challenges when you try to implement these sorts of toolkits. One acronym that you can think of when either you yourself are trying to do this or you're trying to teach others about how to do a med review is the acronym SAFE. This is, again, from the CDC, their STEADY materials. So you screen, you assess, formulate, plan, and then educate the patient and the caregiver. So in terms of screening, it starts with a good medication reconciliation, identifying those meds that are the highest risk for that individual patient based on their organ function. You're assessing based on the patient's conditions, considering non-pharm options, and always incorporating their values and preferences. And this is really where the rubber meets the road when you're formulating your plan. This is really, really hard to do. These medications are very hard to stop, very hard to reduce the doses of, but really that's what we're trying to do here, simplify the dosing regimen. And then finally, educate. Let the patient and the caregiver know why the changes were made, what the next steps are, how they can monitor for any red flag symptoms. So this is all good and well when I present it, but of course it's very challenging to implement in clinical practice. Clinical workflow is very complex. Medication changes often signify larger changes in medical conditions, and so there's this complex interplay between the drug and the condition for which the drug is treating. So for example, depression is itself a risk factor for falling, and so are antidepressants. And so it becomes very complicated when you're trying to tease out how to manage that. Time is always a precious resource. These are conversations that need to be had, probably between 30 and 45 minutes long to do it right. And so that's a challenge. And then when you're looking at your patient panel, probably not everybody needs to receive this sort of screening. And so really identifying those high-risk patients. And then finally, reimbursement. These are some resources. So again, go to Study, the CDC's website, to find more. This is an example of a document that they put out that really summarizes a lot of what we said, or a lot of what we talked about today. In addition, the National Council on Aging is a great resource. They have a lot of patient-friendly materials. And I know this is already on everyone's calendar, but if it's not, the first day of fall, coming up in September, is Fall Prevention Awareness Day. And again, the NCOA has a lot of great materials. If you're interested in doing some outreach in your practice, this could be a great day to kind of raise awareness for fall prevention. And so finally, I just wanted to share this quote from Mary Tinetti, who has done a lot of the seminal work in this area that really is the essence of what I've talked about today and what we're always trying to do, is to eliminate unnecessary meds and reduce or minimize the dose of other necessary meds. We can often treat coexisting conditions while minimizing the risk of med-related fall and injury. So again, that's our goal. It's easier said than done. So any questions or comments?